Hello, and welcome to the CMEO Snack, Finding Function, a holistic approach to managing osteoarthritis. This educational activity is supported by an unrestricted educational grant from Pfizer Incorporated. I'm Alan Gabowski, professor of medicine at Weill Cornell Medicine and attending rheumatologist and co-director of the Clinic for Inflammatory Arthritis at Hospital for Special Surgery in New York, New York. Today's activity is eligible for American Board of Internal Medicine Maintenance of Credit certification, as well as CME for the MIPS improvement activity. Complete your post-test and evaluation at the conclusion of the activity, and be sure to fill in your ABIM ID number and date of birth on the evaluation so your credit can be submitted to the ABIM. Over the next 90 days, actively work to incorporate improvements in your clinical practice from this presentation and complete the follow-up survey from CME Outfitters in approximately 3 months. CME Outfitters will send your confirmation of your participation to submit to CMS, attesting to your completion of a CME for MIPS improvement activity. Our learning objective for this snack is to integrate pain management tools for individual pain and function assessment, goal setting, and monitoring. Let's take a moment to look at the burden of osteoarthritis on the patient. Of course, there is burden on the joint. Joint pain, joint stiffness, joint tenderness, joint swelling. But the effect of joint pain causes functional limitation and loss of independence, poor sleep quality, fatigue, and in many patients, depression. What outcomes are important to rheumatology patients? Well, you see here a survey of patients from the Arthritis Power Registry, 64% of whom self-reported osteoarthritis. Patients were prompted to select up to 10 patient-reported outcome measures they thought were important to track for their condition via a mobile and web-based app, and the results were recorded at 3 time points over 3 months. You can appreciate fatigue, mental concerns, and pain ranked in the 80% level of respondents, and decline in social function, sleep in about 2/3, and morning joint stiffness, a symptom often thought to be associated with other conditions important here in osteoarthritis to the patient. The association of pain and depression requires consideration of a biopsychosocial model of pain management. By this, I mean the interaction of biological factors, social factors, and psychological factors all coming together to result in or augment pain for a given patient. Among the biological factors are what it is that's generating pain, the precision of the diagnosis, the age, the illness, neurologic, genetic, hormonal factors, obesity, and whether or not there has been an injury to the joint. Among the psychological factors are the patient's baseline mood, stress, coping mechanisms, again, whether trauma has been present, and believe it or not, childhood factors. And social factors include cultural factors, economic factors, social support mechanisms, spirituality, ethnicity, education, and the stigma of reporting pain in certain populations. How do we manage the patient with osteoarthritis? Well, we have recent guidelines from the American College of Rheumatology and the Arthritis Foundation, which allow us to look at effective management of patients with osteoarthritis of the knee and hip. You can appreciate here listed are the pharmacologic approaches, such as oral nonsteroidals and topical nonsteroidals, which are strongly recommended. Oral for the knee and hip, topical for the knee alone. and then intra-articular steroids, acetaminophen, tramadol, and duloxetine for both, and topical capsaicin only for the knee. Looking at non-pharmacologic management for the knee and hip, there are a number of modalities strongly recommended, such as exercise, walking, neuromuscular training, and aquatic exercise, self-efficacy and self-management programs, weight loss to reduce the stress on affected joints, use of assistive devices like a cane or a tibiofemoral knee brace where the knee is involved, and interestingly, even the gentle joint movement that Tai Chi can provide. Conditionally recommended for the knee and hip are things like heat and cooling, cognitive therapy, acupuncture, and balance training. For the knee, taping, bracing, yoga, and radiofrequency ablation are included. The patient with osteoarthritis is not cared for in a vacuum. In fact, the most effective way of caring for the patient is a multidisciplinary or team approach. The patient will, at various times, employ the services of the general practitioner, certainly, but coordination with a rheumatologist may be necessary, a physical or occupational therapist, a dietitian, and, appropriately in some instances, a psychologist. The participation of all members of a healthcare team may permit a more effective treatment approach and, in so doing, achieve a better outcome for the patient. Clinical trials with physical modalities and mind-body approaches often yield low-quality evidence because blinding with active treatment is not always possible, which results in a preponderance of conditional recommendations. However, most patients are likely to derive some benefit from referral to physical and/or occupational therapy modalities, such as exercise, self-efficacy and self-management training, thermal therapies, and instruction in the use of and fitting of splints and braces. Not all of these may be appropriate for every patient, but some of them will be appropriate for most, if not many. As important as it is knowing what to do, it's important to know what to do. And so there are a variety of recommendations from the Arthritis Foundation for non-pharmacologic management that should not be employed. Included are the employment of a TENS unit, manual therapy, massage therapy, modified shoes with wedged insoles, and pulsed vibration therapy. A systematic review of close to 3,000 studies found that patients were dissatisfied with the amount of knowledge received and unclear explanation from their healthcare provider. Patients usually express a strong desire for better information, and unfortunately, many times healthcare providers are not providing patients with the information that they are looking for in order to satisfy their curiosity as well as need for information about therapy. Patients thought in these surveys that healthcare practitioners were frequently not explicit about the seriousness of the diagnosis and the prognosis of osteoarthritis. Patients want healthcare providers to use language they understand. Many terms are misunderstood by patients. Cartilage, inflammation, rehabilitation, rheumatism, effusion are often misunderstood or not understood. For example, in this survey, patients thought of effusion meant that bones were being fused together. Effusion, fusion, you can see how those terms can be misunderstood. Terms like wear and tear are approachable, though some patients, women in particular, linked it to getting old and thought that the diagnosis was not being taken seriously by the healthcare provider. Patients want more information to understand their disease, but also importantly, to help them communicate with the healthcare provider so as to become active partners in the management of their care. This leads to an overwhelming concept of the need for shared decision making. We have moved away from healthcare practitioner paternalism to patient autonomy. And in this construct, in this dual partnership, we need to create a supportive environment for open discussion, to clarify the timeline needed when a decision has to be made by the patient, including the opportunity to revisit the timeline at subsequent visits and engage social support such as family or other caregivers as appropriate. Patients want to have clearly identified decision outcomes and the outcomes affected by these options. We need to check the patient's understanding of everything involved in each option and outcome and provide basic patient information as needed. We can't assume that a patient who is sitting there nodding at us understands what we're saying as much as they're just indicating that they're hearing noises. We need to obtain evidence about the outcomes of different options and then translate the evidence into the individual patient's situation. We can select the options and outcomes of most relevance to the patient, so long as it will be the patient who is going to select the outcome used based on the information provided. We should communicate the expected probabilities of different outcomes for the decisions, and then engage the patient in a discussion of their values and preferences. We should offer advice as the patient requests it to inform their decision, and as often as the patient requests it to inform their decision. And finally, we need to be supportive of the patient's selection of an option and not dismissive. So let's review our SMART goals. We can use patient-reported outcomes to better understand what symptoms of osteoarthritis are negatively impacting their health-related quality of life. We should take the time to educate patients about their disease and treatment in terms that they will understand and using words that are meaningful to them and not words of art to us. We should, to the extent possible, keep in mind the biopsychosocial approach to the management of all diseases, but in particular a chronic one such as osteoarthritis, and integrate non-pharmacological interventions into treatment planning. They are not mutually exclusive. Pharmacologic and non-pharmacologic interventions go in tandem and can be used together or adjunctively at different stages of disease. Most important, we should be engaging our patients as partners in their treatment decisions because numerous studies have shown for several diseases that an active physician-provider partnership leads to better outcomes. A number of additional snacks are available for your review, and I encourage you to look at these when you have a moment. The Rheumatology Education Hub of CME Outfitters has a number of free resources and education to educate healthcare providers and our patients on osteoarthritis and a wide array of other inflammatory disorders. To collect credit for this activity, please click on the link shown and complete the post-test and evaluation online. Be sure to fill in your ABIM ID number and date of birth on the evaluation so your credit can be submitted to the ABIM. At that point, participants can print your certificate or statement of credit immediately. Thank you for participating in this CMEO snack. I hope you found it useful and educational and will be able to employ its information to the effective treatment of your patients with osteoarthritis.